Okay, I will start to introduce our distinguished speaker today, Brett Pollock. We're really excited to have him today. Brett and I met recently at a Google meeting, and I heard him speak about Healthy Davis Together, and it's really an exciting project, and I'm sure you will enjoy it as much as I did. Brett is, but I heard actually before I heard him speak, I heard a lot of rumbling for 2 years about this project in the field. Everybody I heard it from different areas, people, sponsors, scientists, everybody was excited about it. So I think it's really important, especially now at this transition phase in the pandemic, to hear what we can learn and how we can move forward in the future. So let me quickly introduce Brett. He has a long CV. He is a distinguished professor of epidemiology, the chairman of the Department of Public Health Sciences, and the associate dean for public health sciences, currently at the University of California, Davis, at the School of Medicine. He is also a fellow of the American College of Epidemiology. But before Davis, he was at other distinguished institutions and has set up there as founding chairs the departments of epidemiology and also biostatistics, for example, at the University of Texas Health Science Center at San Antonio, and also at the University of Florida, where he was the founding chief of the Division of Epidemiology in the Department of Health Policy and Epidemiology, and was also the vice chair for research. He is originally really made in California. He trained at UC Irvine, and he got his MPH and PhD in epidemiology from the UCLA Fielding School of Public Health. So before COVID, and still now, Brett is a leading researcher on the epidemiology and control of childhood and adolescent cancers. He has been at the heart of many distinguished NIH and CI programs, and he has been serving as several national leadership roles, including as inaugural co-chair of the NCI Cancer Care Delivery Research Steering Committee and the NIH-sponsored Clinical and Translational Science Award Consortium, as chair of the Biostatistics, Epidemiology, and Research Design Committee. And he was also the past president of the Association of Clinical and Translational Statisticians. But in 2020, he was appointed as the chair of the University of California's system-wide public health COVID-19 work group, continues to serve as this chair, and he's the director of the Healthy Davis Together project, which is a large demonstration project involving not only the UC Davis campus, but it's really a partnership between the city of Davis and UC Davis. So it really encompasses the schools, also special populations like the unhoused, congregate livings facilities, and migrant farm workers. So it's a very excited integrative project, and we're very much looking forward to learning more about it. Brett, please take it away.
Thanks, Melanie. I'm going to be disappointed by my talk after that introduction, so thank you. Well, thank you for having me, and just one apology up front. I'm using a new MacBook Pro. I have not used a Macintosh computer in 25 years, so I'm still trying to get my way around here. I know Windows inside and out and Zoom on Windows, so there may be a little bit of a hiccup or two. But anyway, thank you for having me, and it's a pleasure to be here. And I just want to preface things by saying that I really consider myself more of a molecular epidemiologist. I did my undergraduate in molecular biology at Irvine. And as an epidemiologist, I've always been much more focused on the translational side of things and done some work in terms of looking at HIV malignancies in kids. I ran a national study, but really involved a lot of laboratory work. And I have to say that this project, this Healthy Davis Together, is a little bit of a different gig for me. It is actually involves some laboratory work, but mostly health behavior, which is something that we learn about, but I really got immersed directly in it. So let me go ahead and start here. So Davis is, you guys know we're not that far from San Francisco here in the Central Valley. And the Healthy Davis Together project was a partnership that we started with the city of Davis back in June of 2020. The goals were really simple: try to lower the burden of COVID-19 in the Davis community, so to extend beyond what we were doing on the campus. to facilitate a gradual and coordinated return to regular city activities, including the reintegration of students back into the Davis community back in the fall of 2020, when people were really worried about these kids coming in from all over the country. They are carrying contagion in high areas of occurrence and coming back to the Davis community. But in addition to those things, we also were trying to identify some replicable and scalable approaches that could be used in other communities and generalized to other communities. So basically, we started the project, as I said, in June 2020. It actually launched later than that, but that's when we started the planning process. I'm going to just review a couple of the general considerations here. So first off, why would we want to do this in Davis? Okay, so Davis was a good place to launch a project like this, mainly because we're trying to do a community intervention. Davis is relatively isolated geographically. It's about 15 miles from Sacramento, west of Sacramento, and there's a big floodplain, if you haven't been out here, between Sacramento and Davis. And then Davis is surrounded by farmland. It's got a manageable size population, about 70,000 residents, and that's in contrast to having 41,000 students or so at UC Davis. The local economy is obviously very dependent on the students and on the university. And there's a high level of cooperation between the city and the university. So that was already a place to start with. And finally, we of course have the assets with a healthcare system, very extensive research and laboratory resources that are available here. So in March of 2020, the committee that I ran, the UC System-Wide COVID-19 Public Health Work Group, we put together the guidance document that got the students out of the classroom and went to remote instruction. That was delivered to the chancellors in March of 2020. It took about 2 weeks for all the campuses to kind of transition to the new norm. And then really by the middle part of 2020, we had a well-developed UC Davis campus ready plan like the other campuses did. In June that year, I got a call from my colleague Tom Nesbitt, who said, hey, we might have an opportunity to get some external funding. If we were going to do something in the Davis community, what would we do? So I sat down on a Sunday afternoon and just kind of sketched out, if I could kind of move forward and see what we could do in the community, how big could this thing be? What would we do? So I kind of drew out the first sketches for this thing. And the first thing we did was we called the city manager of Davis, Mike Webb, and got him involved. We called the superintendent of the Davis Joint Unified School District, and we brought in some other community leaders, and we just started talking about, okay, if we're going to launch a project to try and keep the burden of the disease down, how could we work together? So the partnership was formed at the very beginning. This next slide here is really the schema for the whole project. A lot of stuff going on here, but basically it's kind of divided into two major themes. The first one is epidemiology or infectious disease control, and that's in the top box here. You'll see a number of things that we were planning to do, which included testing, contact tracing, even some exposure notification, but really isolation and quarantine, making those available to the community. Not a problem for the campus, but a big problem for the community because somebody would have to do that. So we also worked on developing an environmental monitoring facility. We had a modeling team here. We did PPE distribution. And we knew that SARS-CoV-2 vaccines were going to be on the horizon. So even though we didn't have them available when the project launched, we had a slot for doing that there, and also how we'd focus on doing some of these things, the testing in particular for schools. That was the first theme. The second theme is health behavior change, and I'll talk a little bit more about this. But the idea was to put together health behavior change interventions that were going to facilitate reduction in risk. So, of course, we knew about the non-pharmaceutical interventions, the masking, keeping distant, trying to prefer outdoor versus indoor spaces to try to keep the infections down. We knew about those early on, but in addition, there were other things that developed along the way, not least of which was the vaccination later on when the vaccines became available. So we had a whole cluster of health behavior change interventions that we did. And of course, the target beneficiaries include this laundry list of the whole population of Davis, people that worked in Davis and so on. To help get the project moving along, internally, we had a number of core facilities here, including an informatics core, innovation technology, administration. We had an enabling environment to look at how we'd use city spaces safely. We had a special populations group, and then the knowledge sharing group, which is really gone into high gear now. Now that we have some results, we're really trying to produce peer-reviewed publications, but we produced a number of playbooks and white papers as well. So just to show you a couple of things on the epidemiology theme, we actually, through our UC Genome Center that's run by Richard Mitchell Moore, Richard is a plant, he's a plant geneticist, and he actually works on plant pathogens. And he recognized, actually just before the summer of 2020, that the conventional methods for doing PCR testing were not up to scale. This is on the medical side, the pathology side. They just weren't able to scale up to a large volume. He does plant pathogens in lettuce, for example, and in the ag biotech sector, there's a need to do much higher volume PCR testing for RNA, DNA viruses, and so on for plant pathogens. So he had this idea of going ahead, and LGC has this IntelliCube system that uses a ribbon tape substrate with microwells to do these PCR reactions, but to actually put that into place here to do testing that we needed to do at large scale. And that machine had the capacity to do about 10,000 PCR tests a day. And that's in contrast to what we were able to do at the medical center under the Department of Pathology and Laboratory Medicine, where we could maybe do 1,000, and that was pushing it. That was when things were kind of far along. So we utilized this platform for PCR, and we also worked on the saliva-based assay, and we got some help from Cornell and Emory and some other places that had started this. We put that into place because we knew that would be much more acceptable. We did find out that using papain to keep the viscosity, break down the proteins in saliva, worked really well to do this assay. So we did some of our own spin on how we did that assay. And the testing started really on student move-in. So in mid-August, we were set to go by having the point-and-click system. That was the electronic health record system we used for student health. We expanded that to be able to do all faculty, staff, and students. And later on, we had a separate point-and-click instance that I was running in my department. We have a medical surveillance program, occupational medicine program within my Department of Public Health Sciences, where we had another license for point and click that we were able to use for the community setting. So we got the informatics platform set up for reporting. And then in mid-September, when students were moving in to get ready for the quarter in 2020, we had set up our first kiosk testing station in our parking structure. On move-in, students had to come and pick up their dorm keys, but they first had to get tested there. So that was kind of conditional there. We shortly expanded this out to the Greek life residents, to first responders, and some of the key personnel that were on the front lines that would interact with students and other personnel. So we got that started. And then later on, we were able to get a CLIA extension for the Genome Center to be able to use the results to be acted upon as a medical laboratory test. We had to go through state approval and so on. We were also running a validation sample for the first couple months, first month and a half of the testing there, where we were doing nasal swabs with fulgent testing and then looking at that vis-a-vis our saliva assay with the IntelliCube. So we set up a number of community testing sites. This is the one at the Mondavi Performing Arts Center in Davis on the main campus. This is actually showing some scenes from our Veterans Memorial testing site. We set it up at a couple of the local schools as well. So we made it easy for folks to come in, and we offered free testing, free universal testing for anybody who lived or worked in Davis. It took about, if you signed up for the test ahead of time, got your QR code, literally you could get in and out within 5 minutes to get tested. The other thing is, we're able to return test results back really within 24 to 48 hours, and almost all of it was within 24 hours. That's at a time when LabCorp and Quest Diagnostics were taking 3 or 4 days to get the results back. So obviously, if you're going to act on that information, you need to be able to act quickly. And so it was really wonderful to have our own assay we could do, get the results back quickly using our point-and-click reporting system. And again, on parallel with what we did on the campus, did that in the community setting. So, we started our campus ready plan, as I mentioned, at move-in. We started the expansion to the whole community in November of 2020, and actually did some expansion to selected parts of Yolo County, including all of the K through 12 schools in July of 2021. By March of this year, we'd done over 1.7 million tests. It's now closer to 2 million as of today across the campus, the city, and the county. In addition to testing, I should have mentioned here at the bottom, it says, we also provided housing, food assistance, wraparound social support services, and even needs-based wage replacement for people in the community that needed to isolate or quarantine. Made that very easy. We had a number of the apartment owners and hotel owners that made rooms available if people couldn't self-isolate in their own domicile. In addition, we also did wastewater monitoring. That wasn't novel. That was being done at other campuses around the country. But we set it up to not only do the campus monitoring, and of course, the Davis treatment plant. We have one treatment plant for the city of Davis, but we actually set up sub-sewer shed monitoring throughout the city so that we could get signal throughout different neighborhoods. And we were actually doing some genotype, looking at the variant drift over time with wastewater. So we're still looking at that now. We're doing some analyses to cross-match the wastewater with the clinical testing that we did. So one thing to say also here, so we have all this wonderful technology. We had a high throughput test platform, and that's great. You know, for the students, they had to test, and for us employees, we had to test. It was mandatory. But that wasn't true for people that live in Davis or work in Davis that aren't part of the university. And so the issue about having all the technology available doesn't do you any good if you can't bring people to actually use the technology. So we knew when we designed this project that we had to focus on health behavior change as well. And we did a lot of things in this area. This is just an example of one of the billboards we had set up here about, you know, get tested, wear a mask, you stay apart, wash your hands, and so on. The hand washing turned out to be not as big of a deal. Certainly swabbing down groceries from coming back from the grocery store wasn't that big of a deal in terms of any safety stuff, but we did kind of start pushing out some campaigns. We also enlisted students. We established a new workforce of undergraduate students. And in fact, these were what we call our Aggie Public Health Ambassadors. We had over 200 undergraduates sign up for the program. They got paid and they also got course credit. We deployed the ambassadors at first on the Davis campus itself, in Davis, the main campus, but later we rolled it out to the city. And in addition to having the ambassadors who did one-on-one health education with people, they handed out incentive cards, they handed out free PPE and so on. We also had a number of incentive programs for safe behaviors. We had some micro grants that we issued for safe socialization during Halloween, the first year of the pandemic. And we also did a staycation thing if students stayed back and didn't travel during spring break. So we had a number of incentives. We also had some business incentives as well. And we established Healthy Davis Together, or HDT, business partnership program. And we actually went into businesses to see if we could help them set up safer environments. So we would install plexiglass. We would give them some advice about queuing up their customers. And we also gave them preference and made it easy for their employees to get tested quickly and rapidly. So a number of things that we did to try and encourage the right kinds of health behaviors. This is when we moved into the Davis community. It was the Saturday before Thanksgiving in 2020. We moved into the Davis Farmers Market. The Saturday before Thanksgiving is the biggest shopping day for the famous Davis Farmers Market. And we had our APHAs or AFAs deployed there. And that guy in the middle with a bald head with his back, that's me. So I actually got to show up when we had our first foray into the community. And we actually also did the downtown business corridor as well a little later on. So in addition to the ambassadors, we had a massive mass communications campaign here where we focused on, again, changing behaviors. We built awareness and credibility for the program. We encouraged the use of non-pharmaceutical preventive measures. We encouraged regular testing and ultimately vaccination when they became available. And of course, the messaging changed over time. It evolved as there were new challenges and new evidence that emerged about how the pandemic was playing out. We also, as I mentioned, got into the vaccine world, although it was clear that the vaccines were going to be shipped, and they were shipped, in fact, to large healthcare provider organizations and then retail pharmacy chains. So we looked at what we could do in Yolo County, and we augmented the county's vaccination efforts using precision public health approaches to identify the particularly vulnerable and highly at-risk populations. And we did end up opening 8 vaccine clinics throughout the county. We also deployed mobile vans to serve our diverse communities. In particular, we did testing and vaccination in the migrant farm worker camps in Yolo County. We got to a point where we had 86% of the migrant farm workers vaccinated. And that was at a time that the county had an average of about 40% vaccination rates. So that was through this kind of hard to reach folks going into their communities, going in with mobile services and making it easy for folks to get tested and get vaccinated. I just now want to share a couple of the impacts. So we did all this stuff. We spent a fair amount of money, but the question is, did we really have an impact? So the first thing I'll show you, I just wanted to say that we did some population-based survey work. We actually did a survey of residents every 2 months with 300 people in the Davis, in the city of Davis, and then 300 people outside of Davis and surrounding communities in Yolo County. So that was a means of looking at whether we saw some behavior change over time. Testing uptake was really dramatically affected. We saw much higher test uptake, both getting tested, ever being tested, and testing multiple times. And also just the attitudes about how easy it was to get tested. If you see the blue here, you've got the folks that are in the Davis sample, and then the dashed line below is the folks in the surrounding communities there. So we had some very major differences in the testing uptake. By the same token, when we looked at vaccination, we also saw some major differences. And I'll just say that in November of last year, we had 80% of the non-Davis residents that were vaccinated, fully vaccinated, in contrast to 95% of Davis residents. Now, again, there can be confounding effects here for sure, but this was kind of a way of looking at change over time in the community to see whether we were having some impact or not. Probably, though, the most telling indication of the program's impact can be seen in this next slide. This is showing you the crude positivity rates, test positivity rates between Davis in the green on the bottom, and then Yolo County in blue, the rest of Yolo County in blue. And then in that orange colored or peach color, that's actually the state of California. And while it doesn't look particularly impressive maybe it does look a bit impressive for the initial wind down from the first surge. That's on the left side. That's January 1st, 2021. If you look during the Delta surge, which really starts around, this is about June or so of last year, you'll see the green line, the green curve is much, much lower than the other curves. And then likewise with Omicron, which is on the right-hand side, you're seeing some really dramatically different crude differences in test positivity. We're also looking at this vis-a-vis case prevalence rates and so on. Now, knowing that there's confounding, we're doing some work now, and it's not published yet, but we're working on this to look at developing synthetic controls, looking at other communities in California and doing appropriate type of weighting and doing a kind of a straw man comparison between Davis and the synthetic control population. And we've done things where we're matching on both the trajectory of the pandemic and positivity before we started our program, as well as sociodemographic factors, and things such as proportion that are in college. Actually, there's some communities that are very similar to Davis, like San Luis Obispo, which is primarily a college town. So we've done a number of types of control comparisons, but we've developed a synthetic control, and I'll just show you this slide here is showing you kind of the adjusted comparison between Davis and the synthetic control. And what you see here is what you'd expect during the surges is where you actually see dramatic differences. Of course, when things die down, there's less of a difference between the curves, but during the surges themselves, you see dramatic differences here. And this would be essentially a means of controlling for confounding. So that was very impressive for us. And we did some modeling, and this is still kind of, I'd say, hot off the press, but not off the press yet. We're still working on this, looking at the number of cases that we think we averted through our efforts here, about 2,300 cases. And you look at the downstream impacts of those. How many hospitalizations did we avert? How many deaths did we avert? How many productive hours of work did we save, and so on. So we're doing some economic analyses to see what the impact is. And then I know for a lot of folks in the audience here, virology. And so we were probably one of the only communities in the country, I'm not aware of any, that was doing genomic surveillance. And we started doing we actually started doing genotyping using PCR, looking at variants of concern back in February 2021. We did this for every positive case that we picked up in the Healthy Davis Together project. So we were able to map out over time this variant drift, which is kind of interesting. Of course, we were doing a subset. We're also sequenced. We were part of the SPHERE consortium. We were working, I think, with UCSF and others as well. But we were able to do this on a kind of a mass scale for the community, just to look and see when different variants popped in and when they kind of faded out in our community. So that's a kind of separate set of analysis we'll be trying to report out fairly soon. And last thing I just want to mention in terms of impact here, we also have some, this is a very gross economic measure here, but looking at something like labor force participation. So we saw that the reductions in Davis were lower than our synthetic control population here, and particularly after the Paycheck Protection Program ended in May of 2021. But we're looking at an array of different types of economic impacts here, employment also, unemployment, and even trying to get a little bit of a cost benefit analysis where we're looking at the money that was spent for the program versus the return on that investment. And so that's not ready for release yet, but we're working on that currently. So just a quick summary here of the project. One of the nice things here is we've had a whole bunch of impacts, which is great. We did provide over 700,000 free tests to the community. That doesn't count all the folks that were on the campus or worked for UC Davis, students and employees. We collected over 10,000 environmental samples. We were doing air filter monitoring in the schools as well as wastewater monitoring, as I described before. We did support 56 schools in Yolo County with made available testing for them. And had a number of other things. We administered 16,000 vaccine doses, which doesn't sound impressive, but we decided early on that because of the way vaccines are being distributed, that we would, instead of trying to replace, Walgreens and CVS and Kaiser, that we would work with all of the providers and actually find out where we could sneak in there and identify vulnerable populations, which include the unhoused, migrant farm workers, and even folks that live at congregate living facilities, some of the aging facilities. So we really went into those places and with our mobile van and those 8 clinics that we had set up throughout the county to try to get the folks that would normally would have fallen through the cracks. And we worked also with CommuniCare, which is our federally qualified health center partner in Yolo County. We've had some great visibility of this project even before, just as we got this thing going. But in January of last year, we had a New York Times article about the project, Above the Fold, and we've been quoted in many other publications. I will say that the Sacramento Bee refers to us all the time when they start talking about rates going up or down in the Sacramento region. They say from Healthy Davis Together, they found that, and they would fill in the blanks there. But we've also had some really nice coverage, and this is really before results getting released. You may not have paid attention, but on the case positivity slide, I put down the reference. We just got this article accepted in the American Journal of Public Health. It'll be in the August print issue. So there's an embargo going on for any kind of press release for another month or so. But we're very pleased about getting that as our overview paper and have about 4 other publications in development right now with others that will be coming. The other thing I just point out is we had wonderful partnerships. Of course, there were some fundamental partnerships that were there at the very beginning. As I mentioned, the city of Davis, we sat down with the Davis city manager day one, said, let's work together, and then brought other partners in, and the school superintendent, the Davis Joint Unified School District. But as the project evolved, we brought in a number of community-based organizations in our area. We did work with some industry partners, Deloitte, and actually Mathematica has been working a little bit on the economic analyses here and the synthetic control method. So it's been kind of a whole wonderful opportunity to partner with folks. And in particular, it's Mike Webb from the city of Davis, the manager there. And then Amy Sisson. Amy is the Yolo County Public Health Officer. She also happens to be one of my volunteer faculty. And we teach together every summer for the new incoming Masters in Public Health class. So it's been fun working with Amy as well on this project. So there are a couple of major lessons learned here. We did learn that universities can effectively extend their capacity to the communities that they are surrounded by. And we also found that I think combining both epidemiologic infectious disease control measures and the health behavior change together in a synergistic way really resulted in lowering the burden of disease in the community. We did use a data-driven precision public health approach to increase the effectiveness of our interventions and to specifically target more vulnerable segments of the population. And we demonstrated, I think, that forming and strengthening partnerships was the way to get the job done. So that's been kind of a mouthful there. We're really happy with how things have played out. I think that the partnerships in particular led to building trust and cooperation, brought us together. And again, these are very disparate entities. You think about this, a university, government, businesses, community-based organizations, schools, these are all very, very different. But the partnering that we did is probably one of the cheapest things that could be done. If you talk about what's generalizable, this doesn't cost you money to partner. It costs you money to do what you're going to do. But this has been a really critical part of our project here. Where are we going now? Well, we actually have some ongoing work right now. We're working on a healthy Central Valley together, really focused on wastewater monitoring, and we're going to try to add in a sentinel surveillance piece as well for our PCR testing. We've been working with the state, California Department of Public Health. We're doing some of the PCR work now for some of the airports in California, so that's exciting. I just want to conclude with a couple thoughts here. So first, I think there are some good indications that we got some success, that we did lower the burden. We're still working on getting more definitive evidence. We did try to meet people where they were. We tailored our interventions specifically to what would make it easy for people to do the right thing, including making things convenient. We did build a sense of trust and more of a common sense of purpose across the entire community. There was a lot, the branding worked, the color scheme worked. When you drive into Davis, you get off the freeway and go in the underpass, you'll see there's a billboard, welcome to Davis, Healthy Davis Together. People saw the logo everywhere. If you lived in Davis or worked in Davis, you might have been sick of Healthy Davis Together, but that branding was really important because people did listen, and I think that was what was great. So there are some limitations here, as you might imagine. I am actually a real scientist, and I understand experimental design. And this is probably the most unsatisfying chance I ever had to do something from a scientific standpoint, which is to throw the kitchen sink at the problem and not do the science that looks at each manipulation, each intervention we did, test its efficacy, and then build on that and look at synergistic interaction between multiple interventions. We had a pandemic going on, and so we threw the kitchen sink at it all at once. So I'll apologize a little bit for this, but it does make it a little tough to say which particular component, what was the incremental value of each component, and that we're not going to be able to do, but I don't apologize. Also, I got to say that universities are in the discovery business. We do research and development. It's not cheap. So if anybody thinks that the costs that we sunk into doing this are what the equivalent would be out in production, they'd be wrong. And in fact, we're getting to some of this now by expanding out the wastewater monitoring to 4 counties in Central California. The PCR testing, we've actually put that out as a white paper to make it available to folks, but clearly less expensive to implement something that's been worked out and validated than it is to start from scratch and try and figure out whether it works. And again, as I said, I think I lament the fact that we couldn't look at each individual component to see what it did. But we also revealed a couple of major gaps as we moved through this. I mean, I think first of all, the data availability and the data liquidity have been major stumbling blocks. CalReady is our reporting system in California. I've said this on a couple of our UC CDPH calls that we are really kind of stymied because we were not able to get a hold of, yet at least, the kind of granular data we need where we could look at things like covariates, things like socio-demographic factors, geolocation, that we could tie to the individual infectious disease report records in CalReady. We don't have access to that. We haven't. So we've had to rely on things like the synthetic control method, which is not as satisfactory for sure. Also, we don't yet have a good sentinel surveillance plan worked out that would include genomic surveillance. I've talked to the CDC. We've had multiple calls. CDPH is trying to figure out what to do. We think that wastewater monitoring is going to be part of the solution, but we're not sure about that. We don't know how that works with individual testing. Can you set up a probabilistic sentinel surveillance structure? We're going to try to test that out in some Central Valley counties, but that still remains to be seen how to do that. Also, I would say, we had a major challenge in general to our public health infrastructure. I mean, this pandemic caught us, I hate to say it, with our pants down, but it's true. We basically we weren't prepared for this. And there's been a steady erosion since I was a graduate student. When I started UCLA in the Masters of Public Health program, I got a U.S. Public Health Service manpower grant to cover my tuition and a stipend. President Reagan got elected in 1980. I started in 79 and 80. He eliminated those overnight. And to my mind, from a personal standpoint, that's the start of the erosion of support for public health infrastructure. And I think, now people are waking up, so that's a good thing, but I think we could have done better. And then I think the other thing that's really important here is the value we place in translational research and new technology. And I'll just give you one quick anecdote. I also do childhood cancer, as Melanie pointed out. I run the prevention program for the Children's Oncology Group, and I put together a protocol that got approved in record time. We just launched last month a prospective cohort study of children and adolescents and young adults that are undergoing chemotherapy that are getting the COVID-19 vaccinations. We don't know how the vaccines work. And because of the need to look at the immunologic changes over time, if you look at serology is much more advanced than it was 2 years ago when we started this whole mess. But it's not far enough along. So we're doing biobanking. After each, there's a baseline sera that are collected, and then every 30 days after each vaccine dose, regardless of what their schedule is, which vaccines they get, and then at 6 months, 12 months, 18 and 24 months, we're doing banking of the sera, because we know that when we're ready to analyze the cohort, the technology would be that much farther along in terms of looking at serologic evidence, looking at epitopes that are specific to things we haven't really figured out how they all work. So the technology is going to drive this thing and drive our ability to handle things. And, the basic biology has been so critical here. So I want to just kind of say that the secret sauce, from my perspective, for this whole project, getting away from the gaps for a second, has really been the partnerships across academia, government, and business. And I think actually the lasting impacts that we're going to see here, locally here, we've expanded our community's ability to respond to new crises, and we've also put lasting infrastructure into place that I think will be useful in the post-pandemic era. So with that, I just wanted to close with a couple of quick acknowledgments here. We have an executive committee that I've chaired. I'm the project director overall, but a number of my colleagues have spent countless hours over the last year and a half working on this. I had 15 hours a week of Zoom calls, as this thing got launched. We had a wonderful community advisory committee, which was co-chaired by our provost and by the city manager, Mike Webb, with representation across a broad swath of the community. We had our scientists and my colleagues that headed up each of our approaches here, and put a lot of time in as well in the technology and applications and so on. And our cores also that were critical at keeping the whole thing running. And last but not least, we had a wonderful external advisory committee that really provided a tremendous amount of input in terms of what we were doing, feedback. Some of these folks represent other universities that had done things like Cornell had put into place a saliva-based platform. Had some wonderful folks here, and Rob Califf, who was at Verily when we got him to do this. I worked with Rob for many years, and he was supposed to be our keynote speaker in February for our pandemic preparedness workshop. He agreed to do that, and then we had to reschedule it because of Omicron. And a funny thing happened on the way to the rescheduling. Rob is basically now back in the position he had during the Obama administration as commissioner of the FDA. So he couldn't be here last week. But I just wanted to point out that everybody here on the group really contributed a lot, and we're happy that we were able to make some progress here. So with that, I'll say thank you, and we can close the presentation out and maybe have a little time for questions, if that's okay.
Thank you so much, Fred. That's great. We have a first question from Warner, who wanted to know, how do vaccination rates in Davis compare to comparable areas in California? And before we go to this, I want to encourage everybody to submit their questions in the Q&A box, and I will pick them up and read them out loud. So Warner wanted to know about the vaccination rates comparable to other areas in the California area, or in California, and what about boost rates?
Sure. Well, I can tell you about the full vaccination rates were higher in Yolo County. And remember, the problem is the data are not as granular as we'd like. And so the county wasn't really reporting out zip code specific vaccination rates, at least not here, because these are very sparse zip codes in Yolo County or other smaller geographic units. So you see overall the Yolo County vaccination rates were higher, as were the testing rates compared to other counties in California. I think they were leading throughout most of the pandemic, in fact. I don't know the booster rate right now locally. Now, what we did was, as I pointed out, we actually did survey work within the city and then outside of the city. And again, a sample of about 600 people every 2 months we did 7 of those assessments. So we did ask about vaccination when that became available. And I reported out, I showed you 95% vaccination rates for the survey respondents in Davis versus 80% for the folks outside. That was back in November. So, things change. And of course, the boosters have come on full strength now. So I would suspect, though, they're higher if we had the data available to us. But that's one of those issues where we just don't have that granular data to allow us to look at the immediate intervention area, which is the city of Davis.
Brett, can you tell us a little bit more how you paid for all this? I mean, this is an amazing, especially the testing program and everything, and all
Sure.
the communication and the billboards and everything on all the people that you're showing here. So I think I think a lot of people would like to do this, but then the question is, how can you make it? How can you pay for it? So
sure. Yeah, I will say that the money came from our chancellor, Gary May. Gary put together a wide swath of different sources of funding for this, including federal and state dollars, including some of the university's dollars. We had private philanthropy also that contributed to this, multiple donors, and made available these funds, which were pretty high and maybe as high when we get done with it. It may be, $30 to $40 million, maybe $50 million total. But it's interesting and I don't actually have the specificity of which things came from which dollars, how much, but I do know that because I was on the campus planning committee and I also ran the UC committee, the amount of money that was at stake for the campuses, I don't know if everybody realizes it, but because of the housing losses that we had in that first year of the pandemic, it was tens of millions of dollars on the campuses. I mean, the scale of the impact of the pandemic on each of the universities was incredibly dramatic. So it sounds like it is a lot of money, but I have to say, if you look at the net impact of the pandemic, short of even this kind of a program, I can't even quantitate that, and we're not going to even know the full extent of that. So putting things into the right scale. That's why we're doing economic analyses now with Mathematica to really look and see what the inputs were. Now, of course, it's not the same beneficiaries, right? There's money spent, and then there's money saved, and health that was improved. And ultimately, if you wanted to get right down to, if you really do cost effectiveness analysis, that's interesting. Cost benefit analysis is where you have to put a dollar value on human life or your quality adjusted life years saved. That gets a little bit trickier, but we're doing some of those analyses now just to see. My guess is at the very worst, we probably broke even, that the money that went in probably, and I think we may have had an even higher return than that. But again, it's a different group of people that spent the money versus those that actually reap the benefits. But hey, that's okay. But again, the seriousness of what happened at the university system and campuses here is not to be undervalued at all. And again, we had a healthier community. You just look at those positivity curves and what is that worth? That would be the other way I kind of think about it.
I was still more interested in your secret sauce. I think that's really a very important part of the whole project. And you said the partnership was at the heart of it, and I have no doubt about it. But what about the partnership? Was it that the community felt that they were not left behind, that you basically took them into whatever you did early on, and then later on they paid back because they felt there was a give and take, or what is really the key of the partnership here that related?
Yeah, so they were not. They came along for the ride. They were in the passenger seat. I should say we swapped off the driving assignments. That the city came along and the community came along as things developed. So that was different. As hey, we got this great thing here, this great program. We told them we're going to make testing available. We advertised it. We made it easy for them to do. They started doing it. The people that took advantage of it said, "Hey, this is great." And especially, I can remember Thanksgiving in 2020, where we were really worried about mass migration events. Not only were we worried about the college students going home to their communities, but what about a lot of the folks that live in Davis? Their kids are coming home from college. So we made testing available for everybody, including visitors. And that had a really dramatic effect. People could actually get a PCR test before they were heading out of town for Thanksgiving. If they had relatives coming in, they could come and stop by and get tested, no problem. So I think the impact of that kind of partnering was the community didn't feel like they were getting second fiddle. They were there with us, moving along in the same direction. And I do think that was maybe just a little bit of luck because we had great city leaders. I think we have great university leaders. I'm supposed to say that because we work for the university, but I think that was part of it. And then even some of our business partners, the Downtown Davis Business Association, were really key. They got involved in this. We had them involved in doing some of the consultation work. We made funds available for some of the things that we did, and people really got into it. It was kind of like this sense of community pride. And I think that's why I think we've got a good shot at having this lasting infrastructure for promoting health way beyond COVID. I mean, I think that's what we're going to try to capitalize on. Again, it's kind of funny. As a molecular epidemiologist, I'm going back to my public health roots. I got my degree from the Fielding School of Public Health at UCLA. This is kind of a fun thing to do. And as I tell my epidemiology students who are really interested in just identifying the next risk factor, doing this really precise analysis, and here I've identified another, and I've done this for my whole career, looking at the etiology of childhood cancers. Oh my gosh, this factor is now associated, we got a 10% increased risk if you were exposed to this pesticide during pregnancy. That's great, but it doesn't do you any good, as I tell my students, if you can't take that and make that into an actionable piece of information. And then what do? Okay, so the whole thing about public health is you start with discovery, and this is kind of like the rest of biomedical research. Basic discovery moves into practical application, evaluation, iteration, refinement, and then sustainability in the population. And these are really neat. And this is what the whole CTSA consortium is about, right? The translational research goes from the basic through to population impact and sustainability and implementation. So it's been very exciting to be involved in a project that really has a lot of these elements all combined. I have to tell you, the work that Richard Mitchell-Moore did in the Genome Center to set this thing up, to have the clever idea of doing this, using this platform, high throughput platform, that nobody should take anything away from that. The things that we're doing now with the wastewater stuff, working with the city and installing a couple hundred monitoring stations, and doing the metagenomics from the wastewater and stuff. I mean, these are just great examples of how science and practical application kind of merge together.
Yeah, that's really great. How did you and your team project manage the kitchen sink approach?
Well, we had a lot of people involved. I will share with you, we brought Deloitte in. I thought that I could handle this project in my department. I'm department chair. And after a first week or so, that was not possible. And then my dean, the dean of the medical school, said, oh, well, we can handle it here in the dean's office. They had it for a week. They couldn't handle it. It went up to the chancellor's office here at UC Davis, and they had it for 2 weeks. And we had to bring Deloitte in, which was great. And Deloitte also provided some in-kind contribution, but they were part of our project management team. We used some of the tools that they've developed internally to manage this project. But it was incredible amount of hours that people spent, the leadership team, the executive committee meeting, 4 to 5 hours a week, plus then all of the other approach meetings like this. So how do we manage it? We basically put a lot of hard work into this. There wasn't like a lot of other recreational things to do during the height of the pandemic, right? So what else are we going to do? But it really was a team effort. And I want to just point that out. I've been the director, but it's kind of like the orchestra conductor. We've got the first chairs that really made the music and all the members of the orchestra. This was a very large orchestra. And I think, again, it was exciting to be part of something where people were into it. There's this brand identification. It wasn't an accident. The Healthy Davis Together moniker kind of says it all, right? It's not COVID. It is something that brings people together. But I think it was just sheer sweat equity and some outside help that managed to let us manage this project efficiently.
And second question, how would you scale up and feasibly implement this for larger cities and communities?
Yeah, so we thought about this. Of course, I think a lot of what we did especially after what we learned, could be lock, stock, and barrel lifted to other college communities. I lived in Gainesville, Florida for 13 years when I was at the University of Florida. There's a lot of college towns that you could probably duplicate almost everything and it would work really well there. We always thought about each individual component. So obviously using a high throughput PCR platform that was really, I didn't mention the fact that when we started this, Fulgent had a deal with us. We were $75 a test for PCR. Our marginal costs for doing our platform were $7 a test, an order of magnitude lower. So scaling that up, we had $1 million investment in the 2 IntelliCube machines and the other equipment we bought. We had the person power that went into this, but we were able to not only get the results returned back within 24 hours, but actually do this at a magnitude of 1/10 the cost. So could that be generalized? Yes. We thought about the health education stuff. How about using university students, undergraduates to do kind of health education? Of course, that could be scaled up at other places, including larger cities. Again, UCLA, maybe they wouldn't have the same impact, but there are things that we thought about. We're publishing these. I wouldn't say that everything would work for sure, but we did think about, well, okay, if we were going to do this, how about going into the K through 12 schools? Of course that would work. And there are some school districts around the country that did things that were similar, didn't have perhaps the same level of penetration that we did. But we actually invited my friend Ron Watkins was here 2 weeks ago for our pandemic prevention conference. He ran the state of Illinois SHIELD program, K through 12 schools. And we compared notes throughout the whole pandemic. They were getting like 20% consent rates for parents to have their kids tested in schools across the state. We had 60% in Davis. Okay, lower percents in some of the other surrounding communities. But those are things, again, that could scale across a whole state. That's why Ron was here 2 weeks ago to talk about how they did that. So I think there are a lot of lessons to be learned. Scalability and generalizability were really important features. We're going to still be dissecting this for the next year or two. I mean, we're just, it's like you did everything. Now we get to do the analysis. For me, it's the fun part. We're trying to get scholarly publications out, but we did do a lot of things to release playbooks and white papers, even on the testing. So how you set up the testing kiosks. They're putting up blueprints down there. That could be picked up by other communities to set up similar types of testing.
And so what do you do now? Are you full-blown going ahead with all this? The testing still open? What is and sort of what is the status and what do you think is the challenge? So what is the next thing that you're adding to your repertoire here? Right.
Testing is stopping at the end of June. Actually, we didn't have the money to continue this year. So at the end of last year, we approached the city of Davis. They used some of their Recovery Act money. They've been paying the incremental costs for the testing. We approached Yolo County, and they're paying for testing also. So that's going to end at the end of June right now. This is this massive PCR testing. We're picking up more wastewater monitoring that we're doing. We're partnering with Eurofins. So we're also looking again at how we hand things off because we're not in the business of production, right? And Richard's lab, the Genome Center is not a production lab. So we are definitely trying to get out of that business as we move forward. And of course, things have changed as well. Michael Minna, it's funny, Michael was one of the major thought leaders about, rapid testing, imperfect tests, but done frequently. We were on a panel together last year for Deloitte, and we had a little chance to talk before. And it was the day after the CDC announced that you can hug your grandkids if you're fully vaccinated. In the same guidance, they said, and you don't need to be tested unless you're symptomatic. And so that was the day after Michael and I were on this panel. I said, so Michael, what do you think of the guidance that we saw yesterday? He said, I nearly fell off my chair. I said, of course, you're not going to test. We know there's asymptomatic disease, but you're not going to test anymore unless you're symptomatic. How stupid is that? So, but what he's proposed is, again, the home testing. He had this idea that by the end of 2020, we would have $1 litmus paper type tests available before you go out. Dip it in there, before you go to work, before you go to school. You could test every day. You had everybody tests every day before they go out. If it's positive, you stay home. That didn't happen. We did get the home test kits. Later than that, they were much more expensive, not quite scalable. But we know when President Biden sent out test kits, if you're relying on central laboratory reporting of PCR results to track this pandemic, you'd be out of luck because people are not doing that. So we've got some other challenges ahead. And I think also the key thing is going to be to develop a sentinel surveillance system. Influenza is done with clinical practices that sign up to deliver sera. We haven't really quite figured that out, nor has the CDC yet. nor has the California Department of Public Health. So I think the next big thing we need to work on is how do we set up, appropriate surveillance here, where we have probabilistic sampling in the population. Again, maybe combined with wastewater monitoring. Those would be the kinds of things I think that will move us into the future. Oh, you're on mute, Melanie. I'm sorry.
The air filter monitoring. I picked this up sort of in between. Didn't work.
No, and my colleague David Coyle, first of all, it was a great idea. He also did contact surface monitoring as well in classrooms. It didn't quite work. And as I said to him when we were starting this, I said, hey, it's kind of a researchy thing. He said, it's not researchy at all because we got the assay correct. I said, no, the use of air filters and filtration systems in classrooms and other places, that's researchy. And he was arguing with me. I just saw him 2 weeks ago at our conference here. He says, no, you were right. It was researchy. And he published a paper, and it just didn't work here as we thought it might. But that's okay. That's why we do research. That's why we do R&D. We spend the money, we answer the questions. And I've had my whole life of doing clinical trial support in childhood cancer nationally, where we do these national clinical trials. If you have a negative result from a clinical trial, it is as important as a positive result. So we get those published because you don't want people using those drugs or those regimens, right? So negative data, negative results are super important. And we did get that published. So we won't have everybody kind of chasing their tails trying to do the same thing.
Okay. Well, thank you very much. This was a really great talk, very inspiring. We will be watching Healthy Davis together for the next foreseeable future to see what we can learn from you. And I know you have a few meetings. I'm looking forward to seeing later today. And I thank everybody for attending and wish you a good rest of the day.
Thanks for the invitation. Thank you. Bye-bye.
Bye-bye.